Good morning. My topic is comparative study, magnocellular stimulation versus occlusion therapy, a prospective case control study in amblyopia treatment. Amblyopia is a developmental disorder of spatial vision affecting 2 to 5% of the global population, where the current gold standard treatment is occlusion therapy, that is patching of the dominant eye to stimulate the amblyopic eye, where the success rates were seen to be 50 to 75%. And the major limitations of current therapy included treatment adherence, psychological impacts, and practical difficulties when the amblyopic eye vision is severely reduced. Coming to the magnocellular stimulation, which is a new approach. Dr. Santan Gopal et al. He has introduced an orthoptic magnocellular stimulator, which was based on the magnocellular stimulation, and his results showed that there was 64% improvement in visual acuity and 97% in stereo acuity. So this is based on the saccadic movement, which was confirmed by Peterson SE et al. That is, maximum foveal stimulation occurs during the initiation of the saccades, which he studied using a series of 5 positron emission tomography experiments. Coming to the occlusion pathway, that is major pathway of occlusion, parvocellular pathway. Here, when the light reaches the fovea and the information is passed through the lateral geniculate nucleus and to the primary visual cortex 4C beta area where the foveal stimulation occurs. And in our orthoptic device, that is the magnocellular pathway. Whenever the reflex saccades initiates, the information is passed to the lateral geniculate nucleus of area 1 and 2, and from there it is again conveyed to the primary visual cortex, and that is the 4C alpha area of the primary visual cortex, and from there the impulse is again further processed to the posterior parietal cortex, and information from the frontal eye field and posterior parietal cortex through the top to down impulses reaches back to the primary visual cortex, and which causes the foveal stimulation. Now, aim and objective is to study and compare improvement in visual acuity with magnocellular stimulator and occlusion therapy in the management of amblyopia. Secondary objective is to see the improvement in stereopsis. It was a hospital-based randomized prospective case control study, and the patients were diagnosed with amblyopia attending the pediatric ophthalmology clinic from May 2023 to November 2024 was included. Amblyopic children of age group 5 to 12 years and refractive amblyopia, strabismic amblyopia, and best corrected visual acuity less than or equal to 6/12 and also not those children not undergone occlusion therapy in the past 6 months were included in the study. Defective vision due to trauma to eyes, deprivation amblyopia, defective vision due to retinal pathologies and optic nerve pathologies were excluded from the study. The target population of 81, that is 41 in the occlusion group and 40 in the orthoptic group of age group 5 to 12 years with confirmed amblyopia attending the pediatric ophthalmology clinic were taken for the study. Consecutive sampling done, and they were divided alternatively into both the groups. Snellen visual acuity values recorded and was converted to their corresponding logMAR values. Stereo acuity was measured using TNO test wearing red-green goggles and graded. Now, occlusion therapy protocol, which was based on the pediatric eye disease investigator group guidelines, 2 hours daily patching were advised, which was monitored by parents. Magnocellular stimulation protocol, the orthoptic device protocol involved a 30-minute structured 2 programs with LED light tracking exercises. It had 2 programs with each having uniocular movement 800 times and binocularly 500 times. Total duration was 7 months, which included a total of 17 sessions, and the follow-up was done at the end of 1, 3, 5, and 7 months for the parameters of best corrected visual acuity and stereo acuity. Now, 41 eyes in the occlusion group and 40 eyes in orthoptic group with amblyopia of age 5 to 12 years were included in the study, and the study was statistically analysis was done by a statistician. Now, assessment of change of the best corrected visual acuity at different time points in the occlusion group showed that significant and consistent improvement in visual acuity from baseline, and that of the orthoptic group showed that also showed significant and consistent improvement in visual acuity from baseline. Now, comparison of the best corrected visual acuity between both groups showed that at 1 month, orthoptic group had a statistically significant improvement over the occlusion group. Beyond 1 month, both the groups continued to improve, but the difference between them was not statistically significant. Now, change of stereo acuity from baseline at different time points in both groups showed that occlusion group had a gradual improvement in stereo acuity, and the orthoptic group had a more rapid and significant improvement in stereo acuity. Now, comparison of the stereo acuity between 2 groups. The improvement in stereo acuity observed in the orthoptic group was found to be statistically significant compared to the occlusion group. The study was done to compare benefits of orthoptic magnocellular stimulation with occlusion therapy in children with amblyopia in the age group of 5 to 12 years. And the percentage children having improvement in visual acuity in our study was 87.8% with the occlusion group and 85% with the orthoptic group. Now, the percentage of children having improvement in stereo acuity was seen to be 77.5% with the orthoptic group and 29.3% with the occlusion group. So at 1 month, orthoptic groups showed a statistically significant improvement over the occlusion group, but at 7 months, both groups showed almost similar improvement, that is 87.8% in the occlusion and 85% in the orthoptic. Now, a substantial improvement in stereo acuity was found in the orthoptic group throughout the study, that is 77.5% for orthoptic and 29.3% for occlusion. The superior stereo acuity outcome in the orthoptic group is attributed to the binocular approach of the therapy and higher compliance as each session done and monitored at hospital. Now, strength of the study, no other similar comparative study available in literature and able to monitor at hospital. Limitations, difficulty to recruit children as they have to come to hospital for sessions, small sample size and follow-up time was limited. So to conclude, the improvement in visual acuity in orthoptic group was higher in the first month, though at the end of 7 months was almost similar in both the groups. Stereo acuity improved in both groups, but the improvement seen in orthoptic group was very significant, that is 77.5% when compared to occlusion group, that is 29.3%. So our recommendations are increasing the frequency of sessions in the orthoptic group over the last 4 months could have led to better improvement, and longer follow-up is necessary to evaluate regression of vision after stopping the treatment. Thank you.
What type of amblyopia? The denser the amblyopia, then outcomes change. Yes, that's so. So in an anisometropic variety, in a strabismic variety, in a sensory deprivation variety, how much of that initial cause for amblyopia affected your outcomes you haven't shown? That should be shown, point number one. Point number two, whether both have synergistic effect. Should somebody choose to do both orthoptic and this occlusion, will it have a role? That also is not brought out. Okay. That also should be brought out. Okay.
Okay, sir.
The other practical aspect is the vision therapies are going to be they're going to include money, right?
Yes,
so what do you charge in your institute?
That is, we charge as per a 7. This is total duration is 7 months, a total 17 sessions. So we are giving us a package in 10,000.
Okay, so all total. The parents are billing for it. Okay. Other thing was microtropia looked for. Microtropia is another unseen, undetected cause which is labeled as this amblyopia vaguely. Was that looked for specifically? Mm-hmm. I think unilateral amblyopias with subnormal vision, not very drastically reduced, please do a Pope prism base out. Okay, now we can also see to what extent these conditions also improve with occlusion therapy and with vision therapy. Okay. Okay. Did you try those patients with vision therapy with occlusion alone? Did you try switching them over to vision therapy after a few months? Because when you knew the stereopsis much better in the vision therapy.
Oh, actually, we didn't try that, ma'am, because the study duration was only 7 months, so we didn't have enough time to do. In future, we can try to do.
That orthoptic, that is mainly for psychiatric moments you are checking, yes, not pursuit and all. No need for that. Because your pathway you have shown, no, something.
Yes, sir.
Huh?
Yes, sir.
From something for the pathway. That is for pursuiters, psychiatrists.
Magnocellular.
Magnocellular, that is mainly for movements, you know that. What the color vision pathway? What's the other pathway in the
parvocellular
pathway?
Yes, sir.
Do you know, for fun gang, I'm asking, what is coniocellular pathway? KONIO. You have not heard, but you are using that, you know that. See, in glaucoma, you are using yellow blue, no?
Yes, sir.
That yellow blue to find out the early problems.
Yes, sir.
That pathway mainly concerned with conio cells, that in the LGB.
Yes, sir.
So when it get affected, the early glaucoma you are telling. That's what you are using a swab.
Yes, sir.
Short wave like the automatic perimeter, no? That is called swab. You are using yellow and blue. That is based on conio cells.
Okay, sir.
You have not heard.
Heard.
Last question. Last, because it is my way of asking questions. Hello. What is amblyopia of misuse? Of course, I am not bothered about this paper, no. Yes, I have most of the papers, you know. But amblyopia, at least before you go, you must know something. Amblyopia of misuse. Don't know. Amblyopia of disuse. No. You're supposed to know all these things. Amblyopia, exanopsia. Don't get frightened now, please. Misuse means the patient gets developing diplopia. Because of that, the one eye is going for suppression. That is called misuse. Eye is normally for binocular vision. So natural diplopia is the misuse. Disuse means we have got ptosis, congenital ptosis. There is no sensation. That's called disuse. Eye is not used. That's all. That's called disuse and misuse. There are some other terminologies, of course, olden days term. Now no, nobody will read. But I studied. No, I have to tell. Thank you.